Good morning. My name is Megan, and I'm one of the internal medicine chiefs. It's my pleasure to introduce today's Grand Round speaker, Dr. Neha Limaye. Dr. Limaye received her MD degree from the University of Pennsylvania and completed a Fogarty Global Health Research Fellowship in Peru on community-based participatory research. She completed her internal medicine and pediatrics residency through training at Brigham and Women's Hospital, Boston Children's Hospital, and Boston Medical Center. She also completed the Howard Hyatt residency in global health equity, where she worked with partner sites in Mexico, Rwanda, and India, and received an MPH from the Harvard T-Chan School of Public Health. She now works at Mount Sinai clinically as MedPeds hospitalist and serves as the assistant director of AMPATH Nepal Partnership. She spends part of each year in Dhulikhel, Nepal, with a focus on improving non-communicable disease care and adolescent health. She also serves as an associate program director for the MedPeds residency and leads the internal medicine residency's global health track. Please join me in welcoming Dr. Limaye.
Okay, am I standing in the right place? Awesome. Thank you so much for that introduction, Megan, and thank you all for being here. It's really nice to see several familiar faces and people I've worked with in Nepal. I'm excited to speak today about our collective journey towards global health equity. I'll be focusing today in particular on inequities in non-communicable diseases, also known as NCDs, which is easier to say, and collaborative approaches to improving NCD care in Dhulikhel, Nepal. This on the side is actually a photo I just took last month on my iPhone of Dhulikhel, Nepal on the walk back from the hospital to the apartment where I stay when I'm there. As you can see, it's a stunning setting. Those are the Himalayas in the background, but also faces many different obstacles and challenges to healthcare that we'll talk about today. So I have no relevant conflicts of interest to disclose for this talk. Thank you. Awesome. So before I start and get into the presentation, I want to acknowledge several people, particularly my colleagues in Nepal, who I wish were here doing this presentation with me. When we scheduled this originally, the plan was to give this presentation alongside a few of my Nepali colleagues from Dhulikhel Hospital. Unfortunately, due to some scheduling and visa issues that happen, I'm giving it on my own, but would have much preferred for you to hear about our work from those who are truly leading it on the ground. I want to especially acknowledge Archana Shrestha, a world leader in NCD research, who is my co-PI on the projects I'll be talking about later, and also one of my mentors. Nishta Bala, who is our program coordinator for our work there, who's contributed some of these slides, along with Dr. Rose House, who's the director of AMPATH Nepal, and our MedPeds program director, Joe Trulio, both for reviewing and contributing a bit to these slides as well. Along with all of the MedPeds residents who are always inspiring me to be more thoughtful in the quest for social justice and health equity that we all share. And finally, I'd like to acknowledge the Arnold Institute and Dr. Riemann, who's here right now, for supporting us all in our various global health journeys. Additionally, as today I'm going to be talking about some somewhat sensitive topics around health equity, racism, and colonialism, I want to just provide my own positionality statement of where I stand as I'm talking about these things. So as you can see on the slide, I identify as a cisgender Indian American female with a high socioeconomic status, and I recognize the privilege that I have based on my cisgender identity, my education level, and my economic background. As I speak about some of these themes, I bring to them both my history of my ancestors in India, along with the privilege of my current life and upbringing in the US. So let's go over the objectives that I'm hoping to cover with you all in the next 45 minutes to an hour. So the first piece that we'll get into is defining what global health equity is and equitable approaches to partnership. We'll also within that talk about the history of global health and some of the colonial influences. Next, we'll appraise the driving forces behind global inequities in NCDs. And finally, we'll move into specifically our work in Nepal, discussing models of community and group-based NCD care in Nepal. Okay, so as we start, I want to make sure we're all on the same page about some initial definitions. I would guess many of you have already seen this image before, but it demonstrates the difference between equality and equity. Equality, what you see on the side in the pink image, is where everyone gets the same, regardless if it's needed or right for them. In the picture, you see people need to cross the road and there's a crosswalk in place, but obviously not everyone can use it, and for some people in this picture, it's further hindering them actually being able to cross. On the other side, in blue, we see equity. Everyone gets what they need, understanding the different barriers, circumstances, and conditions that different people face. The second image shows how we can help everyone cross the road and assist them on their different needs. Striving towards health equity, though, goes beyond just designing equitable health interventions. It's not just the ramp or the traffic light in that picture that are helping people cross the road. To truly achieve health equity, we require addressing the structural and social determinants of health. These are the processes that shape the distribution of power and the distribution of resources in our communities and directly lead to health inequities. This means addressing our history and policies that might affect health and have in the past. So moving from health equity to global health equity, let's carry that definition of health equity with us as we then think about global health. Global health equity extends the same concept from individual communities to a global conviction that everyone deserves quality health care. The way I've best heard it said is in a paper by multiple leaders from Partners in Health, which is a well-known global health organization that I worked with during my residency and had the opportunity to learn from. In a paper they wrote together, they say, "We believe in global health equity because our values of equity and human decency demand that we aim to address the entire burden of disease for all ages." As with health equity, global health equity must go beyond just designing interventions and solutions to the inequities we see. To strive for global health equity, we have to address our shared history and many of the structural and systemic inequities that are a part of the history of global health. So for the next few slides, I'm going to go a little bit into the history of global health, as it's important to understand the discipline's troublesome and dark roots. So global health and the impacts of colonialism on global health started with tropical medicine. Tropical medicine was a movement in the late 1800s, early 1900s that was really alternatively called colonial medicine and the colonial medicine movement. Tropical medicine really focused on furthering colonial aims. By that I mean people cared about the diseases that were affecting settlers. So, for example, malaria was something that was really focused on and tried to be understood through the founding of the London School of Hygiene and Tropical Medicine, because malaria was preventing people from being able to colonize further. So there was a lot of research done on tropical infectious diseases, but the aim behind them was learning how to protect and keep settlers safe as they spent time in colonized lands. Some of the treatment was done of local populations as well, but oftentimes it was tinged with this underlying goal of proving the perceived supremacy of white and Western knowledge. So even if there were settlers that were treating locals, there was always this tinge of racism to it. Tropical medicine then evolved into what's called international health, which was something that the name changed kind of in the second half of the 20th century, and especially during the Cold War. In international health, we went beyond just focusing on infectious diseases and hygiene and transitioned to more focus on maternal and child health. There was this movement of higher income countries trying to help lower income countries and the emergence of these development aid programs. International health was unfortunately still haunted by that same the racist views of tropical medicine, and the development aid programs were often paternalistic and with many strings attached. So it was helping, but with many caveats. And then we made, looks like I froze here, one second. And then we reach global health. So this was at the end of the 1900s and now into this century where international health has transitioned into global health. This was a time where we've all been studying, or at least the time of all of my training, and there was the rise of NGOs and a move from, instead of just focusing on infectious diseases and maternal child health, there was this shift to focusing more on healthcare delivery and health for all, and a hope for more health equity. But it's important to remember that even with global health and now our focus on health equity, that we still have this long history of our colonial origins. And these colonial remnants in global health continue to affect us every day. And that's why I wanted to spend some time thinking about them with you all together. So The colonial remnants affect us at multiple levels. And first is the personal individual level. And at this level, there's this unwritten norm that the developing world, which in itself is a colonial term, is incapable of solving its own health problems. I think about this personal colonial mindset in my own life during the first time I did a global health rotation. I had honestly studied global health for years, had learned a lot of this history previously, but during my very first rotation, actually as a physician during residency, I spent 6 weeks in Rwanda at a rural hospital. And I found myself in those first couple of days working with residents there, really still coming in thinking that I knew best and making suggestions for management, trying to do interventions that really didn't make sense in that context. I remember basically demanding that we, this was a tough situation, but demanding that we run a code on someone that came into the hospital because they were pulseless. And we started the code, and I only realized during it that there was no next step for the code, and that was the reason people had not started a code, because there was no way to intubate, there was no ICU. And it was a very humbling experience, but also just a reminder that I always keep with myself of trying to not come into global health with this arrogance and colonial mindset that I think many people during undergraduate or medical school or during different parts of training have had similar experiences. Next, there's the interpersonal level, where there are practices that further strengthen established hierarchies. We often see these in relationships between individuals in high-income countries as they work with individuals from low-income countries. And the irony is not lost on me, and hopefully shouldn't be lost on you either today, that I'm the one giving this presentation without my colleagues in Nepal. Finally, there are the organizational and structural level remnants of colonialism and global health, where we see that we're empowering those who already have the power. And we see this most in a report that was done called the Global Health 2020 50/50 report that was looking at inequities in global health leadership. And this report, 4 years old now, showed that 2/3 of global health agencies, all of global health agencies in the world, have their bases in 3 countries only: Switzerland, the UK, and the US. And that 80% of global health leaders, CEOs, board chairs, are from high-income countries, and the majority of them are men. So we're really empowering those that already have the power. Zooming in a bit more on academics and research, a field where many of us here today are situated, we also see a lot of data coming out on the effects of colonialism in global health research in particular. For example, multiple papers like this one talk about parasitic and parachute research, where researchers come into a country, make use of local infrastructure and patients, and then go home and write an academic paper. The second paper looks more closely at research done specifically on inequalities in global health, or research on inequalities in global health, and then the inequalities in that, which is a kind of meta way of looking at it, but had important findings. So even within this specific research on inequalities, high-income countries, particularly European and Anglo-Saxon countries over 50 years, disproportionately dominated both first authorship and co-authorship in research. And finally, there is colonialism in global health research funding. This paper looked at the allocation of global funding from G20 countries between 2000 and 2017, only looking at infectious disease funding. And even within infectious diseases, the funding was skewed heavily towards pathogens that were highest risk to high-income countries. So that was HIV for many years, and then Ebola and COVID during specific outbreaks. So research funding was not guided by global burdens or pandemic risks globally, but really just the impact on high-income countries. So now we can recognize all of these colonial forces at play in global health. How do we counteract these forces and begin to dismantle them? I like this definition of decolonization from Laura Makumba, who is a global health scholar at Duke University. The process to her, decolonization is the process of undoing systems of colonialism that govern the global public health agenda and control levers of power that lead to global health inequities. True decolonization requires disruption and a system overhaul, and will take a lot of time. Starting the journey, though, begins with a few central principles that I want to share with you all today. So the guiding principles in moving us towards decolonization in global health are of equity and social justice, and a moral imperative that I think a lot of us share to defend the right to health care for all. We can take these principles to create a paradigm shift that starts at the personal level and move from that norm that I was talking about of the West knowing better than developing countries to true mutual respected partnership in our own individual mindsets. At the interpersonal level, we must address the inequities we were just discussing, eliminating practices like parachute research and instead adopting guidelines aimed at eliminating disparities and mutual accountability. And then at the organizational and structural level, we need to elevate grassroots low-income country voices and change policies of funding allocation and leadership to be more equitable. So then, if we look back at the timeline I was previously discussing of tropical medicine to international health to global health, we can look at it again with a decolonization lens and try and look at other influences on global health. Because we know it was highly influenced by colonialism, but there were also incredible developments toward health equity in the countries that were subjected to imperialism. Here are just a few examples of influences locally on global health. First, the development of community health worker programs, which were locally grown in many different countries, including India and China, and have had huge impacts on local maternal and child health. Second, there are many local grassroots social movements that have moved states and different nations towards emphasizing primary care and universal health coverage. And third, there's so much Indigenous health knowledge and so many medications and treatments that began as Indigenous health practices and are now used widely today. As we move away from colonial influences and move towards equitable partnerships, we must elevate and amplify local and community-based knowledge like this and think about how to work together in more equitable ways. So I want to transition to talking now about the AMPATH model as one example of this journey towards equitable global health partnership. And I want to go more into depth about it. To be clear, I'm not saying that AMPATH is perfect or the solution to colonialism and global health. We definitely have challenges and will continue to have challenges as we grow and are in a process of constant reevaluation, considering what we're doing, how we're doing it, and ensuring that we're not contributing to perpetuating colonial themes. So what is AMPATH? I think you might have heard the name a couple of times in the global health scene here, but it's actually an acronym that means Academic Model Providing Access to Healthcare. It was started in the midst of the HIV epidemic, which severely impacted Kenya, as a partnership between the Moi Teaching and Referral Hospital in Eldoret, Kenya, and Indiana University in the US. The plan and initial mission was to start with HIV care and then do more, which has then since expanded to many types of care. At the core of AMPATH is the belief that long-term sustainable global health goes beyond immediate treatment. Education, jobs, communities, and health are all deeply connected, which is why we work together to empower people in all areas of their lives. The vision is a global partnership to ensure healthcare for all, and that includes people across all partner countries. To achieve this vision, our global network builds partnerships of mutual trust and respect between universities and academic health centers to strengthen health systems, tackle health disparities, train future global health leaders, and foster research and innovation around the world. AMPATH exists in Mexico, Ghana, Nepal, and Kenya with partner sites all across the US and a couple of places in Europe. But I'll focus most on AMPATH Nepal and how we use those values of mutual trust, respect, and accountability. And I'll speak about AMPATH Nepal as that's the site that I know best and the one where I've been working for the past a little over 2 years now. So as with all AMPATH partnerships, we're a collaboration between different partners. So we, as Mount Sinai, are the lead of the AMPATH consortium institutions across the US and Europe, working with Dulikhel Hospital, which I'll tell you more about, and Kathmandu University School of Medical Sciences, which is the medical school and larger university that works with Dulikhel. As with other AMPATH partnerships as well, our goal is to lead with care, but also focus on the overall three-part mission of care, research, and education. So we partner in the delivery of healthcare and strengthening both of our health systems to reduce inequities. We aim to strengthen and develop human capacity through trainings and education, and we aim to advance research to improve the health of underserved and marginalized populations everywhere. So to understand the context a bit more, I think it's worth spending a little time telling you about Dulikhel Hospital, which was founded almost 30 years ago now. So Dulikhel is located about an hour and a half away from Kathmandu in the hilly region of Nepal. And this is the founder of the hospital, Dr. Ram Shrestha, pictured here. He grew up in Dulikel and unfortunately lost his mother due to complications of chronic disease and lack of access to care when he was young. This experience and others in growing up in Dulikel really motivated him to become a doctor. And so he trained as a surgeon in Austria, but always had a plan and explicit purpose to come back and build a community-based hospital in Dulikel. And I will say a lot of people sometimes have a plan like that, but very few that I know have actually done it, but he really did just that. He returned to Dulikel after becoming a surgery attending, brought with him a small team, and then with commitment from the local community, began building a hospital. And what began as just this one building has now expanded into this large structure of multiple buildings, a 475-bed hospital with 18 affiliated outreach centers kind of all across the district and a couple of others. Dulikel has a little over 300 doctors along with many, many trainees, covers many specialties, has an ICU, has hemodialysis capabilities, and runs an extremely impressive number of community-based programs. Dulikel, of course, also faces many resource constraints and challenges, but they always run with this mission to deliver quality healthcare for all, regardless of income or socioeconomic status. So taking all of that into consideration and just the strength of Dulikel and the training and the strength of the trainees there and all of the work that they were doing, Mount Sinai began exploring a partnership with Dulikel before I started here back in 2020, focused on building care, research, and education programs built on mutual respect and understanding and the goal of partnering together. So in 2022, the partnership was officialized as AMPATH Nepal in this MOU signing between Dr. Ramshrestha and then Dr. Friedman, who's here today and is the chair of our Department of Global Health. So since then, since 2022, we've come an exciting way and have started working together on delineating the priorities for our partnership and starting our journey together. In 2023, we hosted a strategic planning with many experts from Dulikel, along with some who visited from AMPATH Kenya, and then several people from the US. And through the course of a multi-day workshop, we determined what our key priorities were going to be over the next 5 years in our long-term partnership together. One of the key priorities that was identified by many people locally, both in the community and at the hospital, were NCDs, non-communicable diseases, which is what I will focus on for the second half of this talk. So let's talk more about NCDs and in particular the inequities in NCDs that we see both globally and then zooming in on Nepal. Just to make sure again that we're on the same page, I'll briefly define NCDs. They are chronic diseases or diseases that are not passed from person to person. There are many, many types of NCDs. We see in the hospital patients that have a broad number of chronic diseases, but the initial focus in global health was on the NCD4, or the 4 core NCDs that make up the largest burden of disease. Those are cardiovascular diseases, chronic respiratory diseases, diabetes, and cancer. And these are the 4 that make up that largest burden. And NCDs have been rising over the past 20 to 30 years, maybe even longer than that. And there's really been an uptick worldwide in the rate of NCDs and also the rate of global deaths by NCDs. And as we think about why NCDs are rising, there's a well-known part of the NCD story, one that is more immediately obvious, and then the part that's more hidden. So this is kind of the well-known part of the NCD story. Some of the rise in NCDs is due to this epidemiologic transition, which some of us might have learned about in public health school or at different points in life. And the overall concept is that as areas become more urbanized and people develop lifestyle changes and the population is able to surpass communicable diseases, is not dying anymore as much from infectious diseases, they grow older and then are more impacted by NCDs. So as the rate of infectious diseases goes down, the rate of NCDs goes up. And this is part of the story, and we do see this pattern happening. And Nepal falls into this middle area where there's a dual burden of disease, where the rate of communicable diseases has fallen, but not completely, and the rate of NCDs is also rising. So they're really having to address both things at once. However, these things, urbanization, lifestyle changes, and aging population, are more proximal causes of NCDs and are not really the whole story. So let's look a bit more into that. When we look more closely at NCDs, we see that while the burden is rising everywhere, the burden is unequal. This map shows the probability of dying from an NCD between 0 and 80 years old for males in 2016. You can see how the probability of dying from an NCD is much, much higher across most of Africa and Asia as compared to Europe and North America. When you get to the orange-red, that's a 60 to 70% chance of dying of an NCD, and you see the areas of the map that are much more orangey-red and the areas that are much more green. This same pattern holds for females, but females overall have less risk of dying from NCDs, so the overall probabilities are a bit lower. And so there are 41 million deaths each year from NCDs, but of all the NCD deaths, 80% happen in lower and middle income countries, many of which are in Africa and South Asia. This same pattern we see if we look just at those core 4 NCDs that I was talking about, and the probability of a premature death, dying between 30 and 70 before one is supposed to, ideally. And we see the same pattern where the probability of premature death is much higher in Africa and parts of South and East Asia than in the rest of the world. 86% of premature deaths also occur in just the low and middle income countries. So what is driving this unequal burden of NCD morbidity and mortality? From research and from talking to people, I don't think it can be explained just by lifestyle changes and urbanization and aging. As we were discussing, to understand global health inequities, we have to look at structural determinants to understand the root causes. This is a sort of busy graphic from a global health epidemiology textbook that shows the many different determinants of NCDs over the life course. But let's zoom in on the top part. Because while there are these individual behavioral risk factors that impact the development of NCDs, like smoking and drinking and lifestyle changes, this graphic also shows that there are these upstream social, economic, environmental, ecological, commercial, and political factors that can lead to this inequitable distribution of NCDs. And I think it's important to think about these rather than just the more proximal factors as we work to design interventions. So let's look at a few of these upstream examples in more detail in different parts of the world. So let's first think about economic drivers of inequitable NCD burden. And this one of the biggest drivers of just less NCD programs in different places is limited NCD funding. As we were talking about, there's been a lot of funding in global health for infectious diseases and for diseases that impact the funders, while NCDs don't necessarily impact people outside of the country where they're happening. And so historically, there was very limited funding for NCD work, for NCD program building. That is starting to change with this rising burden and recognition of the major problem that NCDs are going to cause worldwide. But the lack of funding has really had an impact on which countries have been able to build robust NCD programs. There's also a different burden and impact of NCDs on the world's poorest billion. There's been a lot of research done on this specific population who, by different measures of poverty and multidimensional poverty indices, are the world's poorest. And for them, they have a different set of NCDs that are affecting them. There are still those core 4, but then there are also other diseases where children and young adults are more affected. Things like rheumatic heart disease, type 1 diabetes, sickle cell. And in the world's poorest billion, these people are also facing the impacts of stunting, hunger, and exposure to biomass fuel as other risk factors that can make NCDs worse. Overall, research on this group, the NCDI poverty group, concluded that NCDs are more lethal when they occur among those living in extreme poverty with low access to services. And I think that makes sense logically, but is important to say out loud. And the group that's addressing this is called the NCDI Poverty Network. Nepal is a member of this network as a country that does have some of the world's poorest billion living there and suffering from NCDs. Next, moving beyond economic drivers, another driver of the inequitable NCD burden is political drivers. And we actually can look first just at the US, where there are also inequities in NCDs. So in terms of access to care and policies that can limit access to care, one we see in the US is limited insurance in different places. I've trained and now work in a place where there is easy access to emergency Medicaid and to insurance services, but in other parts of the country, I had spent some time working in Florida during my residency with a migrant farm worker community, and folks there didn't have access to any form of health insurance if they didn't have documentation. And there are examples in the literature of folks without insurance, folks who are often migrants having limited access to care, which is then a known risk factor for poor NCD control. Another example of policies affecting access to care is in the West Bank and in Gaza. Here, for many years, prior to the current war and current crisis, Palestinians have been limited in their movement. needing to pass through many checkpoints and showing identity cards before they can reach certain care facilities as a policy. This here in the picture is a checkpoint trying to leave from Ramallah to get to go on Jerusalem Road in the West Bank, and showing the time it takes to get through that checkpoint. Additionally, if a Palestinian needs an NCD treatment that's not available where they live, which is often the case for cancer care, there's a complex referral system to obtain a health access permit. Multiple analyses of this referral system from 2011 to 2013 show that there were significant delays in NCD care due to this policy. Finally, as an example of political conflict and civil war leading to NCD inequities, we can look at Sudan and the tragic civil war that's been going on there now, and the instability that's been going on in the region for many years. And this is just one example. There are obviously many conflicts going on and that can destabilize and affect NCD care. In Sudan, due to the destruction of the healthcare system from conflict and unrest for so many years, the NCD-related mortality has increased from 32% in 2015 to 54% in 2022. And I don't want to attribute all of that change to the conflict, but research shows that there's been a strong correlation in the timelines of both. And finally, another inequitable NCD burden driver is environmental changes. We're seeing huge impacts of climate change, and they have an unequal impact on different communities. So pollution obviously can lead to respiratory disease, worsening COPD flares, and pollution is inequitably distributed across the world. Similarly, heat, which I hadn't really thought of till preparing for this talk, is something that can really trigger a heart attack, trigger hypertension flares in people that are experiencing heat waves. And we know that climate change has this unequal impact on lower middle income countries such as Nepal, and also on these small island developing states who are often the ones who didn't really contribute much to climate change but are now feeling the brunt of it. And I saw the impacts just now in my trip to Nepal of climate change when I was there. There was massive flooding in October. Usually the monsoons stop in September. That created a lot of road blockages and barriers to care just in the past month. And then last, toxin exposures are another thing that we're still exploring as a potential driver of NCDs. There is a condition known as CKD of unknown cause in agricultural workers, and this is seen in Central America, South America, also Sri Lanka, also India, and the cause is still unknown, but research is pointing towards at least some of that being related to exposure to pesticides and exposure to environmental causes that agricultural workers and lower income workers are more likely to be exposed to. So given this rising burden of NCDs and this inequitable burden of NCDs, there has been a global response and recognition of NCDs as this key priority by large global health organizations. They've made it a sustainable development goal for 2030 to try and reduce by 1/3, by 33%, mortality from NCDs and promote mental health. And the WHO has come up with these packages for PEN stands for the Package of Essential Care for NCDs, and PEN Plus tries to cover more of those additional childhood and young adult NCDs, so the type 1 diabetes and sickle cell. And these protocols have been developed and are now being implemented across multiple countries. So that's kind of the global picture on the inequitable burden of NCDs. Let's now zoom in on Nepal and what's going on with NCDs in Nepal and how we can use community-based interventions to try and address some of these inequities. So Nepal is similar to many other low and middle income countries in that it has a high burden of NCDs and a high burden of death from NCD. So at least 66% of all death and disability in Nepal comes from NCDs, and that was in 2016. The number is projected to rise by the next data that will come out in the next year or two, likely closer to 70%. Half of the disease burden is in those under 40, so it's more of these young adult populations that are being more affected. And hypertension and diabetes are two of the diseases with the highest burden, though COPD also has a large burden. And some of that COPD is from environmental factors and biomass fuel. If we look more closely at hypertension and diabetes as two of those with the highest burden, we see the epidemiology here. So hypertension has a similar prevalence in Nepal actually to the US of between 25 to 32%. But I think in the US it's around, we think 29 to 40% different estimates. The issue is that only 50% of people in Nepal are diagnosed with hypertension, and then a very small percentage, between 4 and 10% based on different studies, are actually controlled in their hypertension. So a large majority of people either don't know they have hypertension or have it and don't have it controlled. Diabetes has a lower prevalence of only 8.5%, also similar to worldwide averages. But less than half of people know that they have diabetes. And there's not enough data yet on who actually has their diabetes controlled. So these two diseases are an area that we really want to work together to address. And there has already been work on addressing NCDs in Nepal. A lot of work has been done because it's been prioritized by the Nepali government. They have a whole multi-sectoral action plan for the next 5 and then 10 years to try and reduce the risk of premature mortality from the different NCDs, particularly focusing on those core 4 NCDs of cardiovascular disease, cancer, diabetes, and respiratory diseases. And the government is working closely with different organizations, NGOs, and the WHO to try and build better NCD programming. And thus far, they've been implementing those PEN and PEN Plus protocols that I mentioned, the package of essential care for NCDs, across the country. And it has been implemented in a wide range of clinics. However, the question that our team right now, the AMPATH Nepal team, is looking at is that implementation in the facilities of NCD care enough? And so Dr. Shrestha, who I mentioned, Archana Shrestha, has been working already for years on this question and has been looking at what are the barriers to NCD care in Nepal after this PEN program implementation. And in her ongoing research right now, what she's found is that there are still many levels of barriers, even if care is available at the facility. The facilities might not have appropriate supply chains. They might not have appropriate training. There are limitations on the provider's time, and then also community and individual barriers that people are facing that are preventing them from being able to even get to care. So our goal as our AMPATH Nepal NCD team is to really focus on, can we address all of these barriers, try and create a better system for NCD care, at least pilot it at a small level, and then use our piloting to influence policies and structures in Nepal and improve policies overall for NCD care. So I'll take the last bit of time to just explain what we're working on now, which is trying to build up a stronger NCD continuum of care. And this means shifting from that facility-based care model where people have to go to the clinic or go to the hospital to get NCD care and receive that PEN care package to a more holistic model. And this leans on the strength of Nepal's robust community health worker system, which includes some professional community health workers who get paid a living wage to be community health workers and go house to house, and then also a huge cadre, I think close to 50,000 volunteers across the country that are female community health volunteers and are representatives of their communities and do home visits and inspire people to engage more in their health. So working with that community health worker system, we're working on creating a continuum of care with the community and CHWs at the center, where we can go from screening to referral to clinics as needed, to then treatment and follow-up, hospitalization, and post-hospital follow-up, but all in this connected circle that really the community is at the center of. The other piece that we're working on trying, which I hope to try in the US one day too, is group-based community care models. So there's a precedent in prenatal care, things called like centering pregnancy and having women who are at the same point in pregnancy get their care together, that has worked really well to improve care outcomes. And now group care has been expanding to other fields. The idea for group NCD care is collective care, where patients with hypertension and diabetes come together and get their counseling done together, motivational interviewing done together, and then have their individual appointments at the same time. The model has not been tried much in Nepal as yet, but we see a lot of potential in group care in other settings. In Mexico, with our Partners in Health group, they've done group-based diabetes care and have found that this patient-centered collaborative model of group care really shifted the power and empowered patients to feel like they had more control over their own health. Similarly, in India, through group diabetes care, they've shown both better engagement in care and improvement in A1C. And then our partner, AMPATH Kenya, has a strong group care model that uses both microfinance and group hypertension and diabetes care all wrapped in one. And in their program that they've been able to expand to many communities, they have shown at least 70% are retained in care at 12 months, and a pretty huge reduction in blood pressure, 21 millimeters mercury in the systolic blood pressure through this group-based care model. So we're then working as the Empath Nepal NCD initiative with funding through the Lilly Foundation to try and co-design, pilot, and expand a community-based care cascade for adult NCDs, starting 18 and up to try and catch that younger population, and incorporating group care into that. We're really just in the starting phases, started in 2020, in July of this year, and we'll be going for the next 3 years. And just want to recognize the Empath Nepal NCD team. Besides me, we have these multiple core team members, Rose, who I mentioned, who's the director of Empath Nepal, our director of all the community outreach centers, Dinesh, our expert in health system design in terms of the mobile component and data collection, Anant, and then our program coordinator, Nishta, and my co-PI, Archana. And so over the next 3 years, what we're hoping to do is go through these multiple phases. So in the first phase, we're working to co-design a culturally relevant NCD care model that includes group care and figures out how to really work with community members, community health workers, and other stakeholders in the community to design a model that is feasible and works in different settings. And we're looking in 2 different settings, one that's more urban and one that's more rural, to make sure it works across different geographies. Our third goal is to strengthen the electronic data systems as we do it, so that we're keeping track of who has NCDs and really creating a registry of who we need to track. In the next phase that we'll hopefully get to in the next year, our plan is to train health workers on this care model that we've co-developed together with all the different stakeholders, and then screen at least 15,000 individuals in our target areas, link the positive cases to care, at least at the clinic, and then pilot that full model of community-based care with group care across 2 of the municipalities in Nepal. And then in our third phase, we'll be expanding to additional municipalities, continuing to conduct these screenings, and then trying to refine this group-based model based on pilot feedback. So in terms of where we are now, while I was there last month, I just got back a couple of weeks ago, we completed our orientation for the Empath Global NCD Initiative in one of our 2 municipalities. And some of the folks pictured in this will be then members of our co-design workshops, which will include community members, community health workers, patients who have hypertension and diabetes, along with local health leaders and the deputy mayor, and work together to co-design. We're currently, as is the reality of global health, awaiting our IRB approvals to be able to get started. It's a process that takes some time, and I think is just a reality to recognize. And then climate change, like I mentioned, is a big issue and having a big impact in Nepal. So unfortunately, the second municipality where we were going to be working, the more rural municipality where we want to test out this model, has been badly affected by the recent major flooding. And actually the outreach center that we will be working with was completely destroyed by the flooding. So we're working on fundraising right now to try and help support them building that back up. But with the hope that we will be able to bring them this model in the future, that it just might take some time. So in terms of our next steps and questions for kind of all of us, our goal is to design this care cascade and the group care model by early 2025, and then begin that phase of piloting and training, working closely with community health workers and local health workers. And I think one of the big questions that I want to leave you with is, what can we learn from the community-based and group care models in Nepal? Is there a way that we can reciprocally innovate together? Because like I was talking about throughout this, the whole goal of these partnerships is really for mutual accountability, mutual respect, and mutual learning. And I think there are ways that we can take what we see in addressing these inequities and NCDs in Nepal and really bring it back to New York. One of the ways that we're trying to do that in a small way is through a collaboration of education between our MedPeds residency program and the community medicine residents who are based in Dhulikhel. The community medicine residency is a different residency that doesn't exist here, but really focuses on the holistic health system. And they do a lot of community visits and home-based visits. And we found a lot of shared understanding between our MedPeds residents who also do community visits and are working to learn together from each other's programs on how we can improve community-based care in both settings. So I'll finish here with just some take-home messages about what we've spoken about today. So first, we must constantly assess and address colonial history's legacy on global health equity today. And in any global health partnerships or projects that we're undertaking, try and remember that history and then also assess and make sure that we're not perpetuating it. We've also seen that NCDs have a growing and disproportionate burden on low and middle income countries like Nepal, and that burden is inequitable and really pushed forward by different structural drivers. And finally, that community-based approaches to NCD care can improve inequities, hopefully both in Nepal and locally in New York and in the US. So that's what I have today. Thank you all so much.